So the meetings are recorded. These meetings are recorded and the recordings are available to everyone afterwards on the VULA site at UCT. We are planning and hoping that in this year we will create a website where this will be accessible with greater ease externally to UCT itself. Great. And before I hand over to Barry, I just want to also say a special welcome to one of our colleagues from Canada, Professor Matthew Seftel, who's also here this afternoon, I see. We've got people usually from different parts of the world, but as our speaker is also from Canada, I'm very glad that Matthew is in the audience. If you have any questions, please put them in the chat box, or later after the presentation, you can just put up your hand or ask your questions verbally. But with that, and without further ado, I'm going to hand over to Prof. Barry Jacobson to introduce Prof. Eichelboom. Thanks, Barry.
Thanks very much, Vernon, for those very kind words. It's a great honor and privilege to introduce John to everybody. I mean, his CV, if we have to give it proper justice, we won't have time for a meeting, John, so you'll excuse me if I abbreviate it. But he's basically one of the key leaders in thrombosis in the world, works at McMaster's. I'm going to try and keep it as short as possible. Numerous awards, impressively the Jack Hirsch Award, and I had the privilege of actually meeting Jack Hirsch, who was the father of thrombosis when I was a junior, and he really was very inspirational, and for you to be carrying on the legacy that he left behind is amazing. John and I mean, John has been on the safety committee of some of the studies that I've been involved in, and he is an international researcher of significance and in the top 1% of people in terms of citations, which is truly impressive. So John, without further ado, I'm going to hand it over to you, and the floor is yours, and we look forward to your presentation.
Wonderful. Thank you so much, Barry. Thank you, Vernon, and also Estelle and Gerdine for super arrangements for this session. I'm really delighted, in fact, very excited to be here, and I'm just as excited to talk about this topic, the future of oral anticoagulation. Indeed, when I think about this topic, I wonder whether I should have titled my talk in the form of a question. The question being, is there a need for further development of oral anticoagulants? Indeed, are there still unmet needs in oral anticoagulation? Well, why do I ask that question? Here we have a snapshot of the development of anticoagulants. And I graduated somewhere a long time ago. I realized I have a daughter in medicine now, and I used to think I was still sort of young or middle career. I realize now, based on what she tells me quite honestly, that I'm one of the old and less connected guys. I graduated here in 1988. And you will notice immediately that when I graduated, we had only 2 anticoagulants in clinical practice, heparin and warfarin. And these were discovered by serendipity. And they were introduced into practice before we even knew how they worked. At this time, we had a desperate need for alternatives to heparin and warfarin. Well, look what's happened in the last 3 decades. We initially had a mini explosion of parenteral agents, and this ushered in the era of designer drugs, designer anticoagulants. But they truly came to their greatest potential with the emergence of designer oral drugs. And you all are familiar with the DOACs or the NOACs, although I understand that at the moment still only one is available in South Africa. But these drugs were designed like keys to fit specifically into locks, into specific coagulation proteins to block them. And they are truly stunning agents. They're very widely used around the world. I can't remember the last time I used warfarin for a patient with atrial fibrillation or venous thrombosis, unless they had a contraindication. And 2 of them well, actually 3 of them now have approved very effective, or in the case of dabigatran, spectacularly effective reversal agents. So again, what is the need? If there is no need, why are we even talking about developing newer classes of oral anticoagulants? So I've structured my talk in 3 points. The first, I want to address this issue of unmet need. Then I will move to what I think is the most exciting, promising area of new anticoagulant development, that is new oral anticoagulant development, drugs that target the contact pathway of coagulation. And finally, I will talk a little bit speculatively about other novel strategies to target upstream drivers of coagulation. Now, for those of you who are trainees at this session, your heart quivers at the thought of coagulation cascades because they appear to be complex and often largely irrelevant to clinical practice. But in fact, they are incredibly clinically relevant, as I will show you when we talk about the drugs that target the contact pathway of coagulation. And at the end of this, I hope you might not love coagulation pathways, but you're going to respect them at least. Well, let's start with unmet needs. And we have 3 areas of unmet need. The first is where drugs are contraindicated. That is, existing anticoagulants are contraindicated. The second is limited effectiveness of the currently available agents. And immediately you'll think, truly, do we have unmet needs in terms of drugs that are not effective enough? Well, we'll get to that. And thirdly, the issue of risk of bleeding. Well, the contraindications are straightforward. One of the most common areas of unmet need in clinical practice in terms of oral anticoagulation is patients with advanced kidney disease. And if you don't think about this very often, it'll come as a surprise to you that no less than 10% of the world's population of 7.2 billion or so inhabitants have chronic kidney disease. A much smaller fraction have advanced or end-stage kidney disease, and that is where the existing oral anticoagulants are the most problematic. But the entire spectrum of chronic kidney disease is a tough area for anticoagulation. We know the problem that patients with advanced kidney disease have high risks of thrombosis and they have high risks of bleeding. And the evidence, well, there is very little evidence in advanced chronic kidney disease using anticoagulants because we've conveniently excluded them from our trials. In retrospect, a huge error, but we continue to compound this issue by repeating that error over and over and over again. And we're doing the same with the next class of oral anticoagulants. But there is some light at the end of the tunnel. There are some trials now that are starting to be done in hemodialysis patients with anticoagulants. So we exclude patients with this disease. The vitamin K antagonists are associated with extraordinarily high rates of bleeding. And in dialysis patients, it appears that the risk of bleeding outweighs any antithrombotic benefit. With DOACs, we're concerned that the drugs will accumulate because they are at least partly renally cleared. So this is problem 1 in terms of contraindication. Problem 2, advanced liver disease. Less common, but also characterized by high risk of thrombosis and very high risk of bleeding. Once again, we routinely exclude patients with bad livers. Now, that's, to me, somewhat more understandable than excluding patients with bad kidneys. Vitamin K antagonists are difficult to monitor when you have a coagulopathy related to liver disease. and the liver partly clears most DOACs. So again, a risk of drug accumulation. This is a second important unmet need. And the third one that is perhaps even closer to home to you in South Africa than to me in Canada is this issue of drug-drug interactions. And whilst the DOACs are a huge advance over warfarin, there are still substantial drug-drug interactions, particularly with antimicrobials, the azole antifungals, the macrolide antibacterials, anti-tuberculous drugs, and anti-HIV drugs. So we've got space to improve there. So far for contraindications, but I'm starting to paint the picture that we have unmet needs. The second is limited effectiveness. And this, I have to confess, is one of my favorite stories in the new anticoagulation discussion. Let's start with anticoagulants for venous thrombosis prevention. And one could be forgiven for thinking that this area has been, so to speak, conquered. After all, if we use an anticoagulant, we reduce the risk of venous thrombosis by about 80 to 90% in primary prevention, and we reduce the risk of recurrent venous thrombosis by a similar margin. So, is there really an unmet need in venous thrombosis prevention? Well, consider the following. It's often thought that venous thrombosis is the third most common cardiovascular cause of death. You will see this written in every major textbook and in many review articles in leading journals. And people just repeat this over and over and over again. Is it true? In the United States, if you don't give prophylaxis in hospital, you could compromise funding to your institution because it is a measure of quality of care. Well, let me provoke your thinking for a moment by showing you the data from this 2020 systematic review meta-analysis by Clement and colleagues, hidden somewhere in Lancet Hematology. And I think this is a very impressive and thought-provoking paper. So what the investigators did, very simple, they took all randomized controlled trials of primary prevention, almost all in hospital, and they restricted it, well, from 1993 to 2018. So when I say all in a period of several decades. And they did two types of analyses. One analysis was all the trials together to see whether there was an effect on VTE, on bleeding and death. But the second is the unique approach here. They restricted the analysis to people or to trials where in fact there was a reduction in venous thrombosis. So if ever you would expect that this potentially fatal disease, if you prevent it, you would expect to see a reduction in mortality, it would be in these trials. Well, the data are shown here in the 52 trials which showed a reduction in VTE. This is a Bayesian approach because you pre-specify that you're selecting out these studies and you pre-specify you're looking for trials that have reduced venous thrombosis. Clearly, there is a highly statistically significant reduction in venous thrombosis. There is clearly a highly statistical increase in bleeding, but absolutely no effect whatsoever on mortality. If we think about that, we're either wasting our time treating VTE to save lives, we're using it well to prevent VTE. All the textbooks might be wrong to say this is the commonest preventable cause of hospital death. I've inserted here preventable. Maybe it's still a cause of hospital death, but it doesn't seem preventable to me, and it doesn't seem that common to me. What's the explanation for this? It's certainly possible that the bleeding just negates the thrombosis prevention and you don't get a mortality benefit. Maybe VTE is not a cause of death. Maybe VTE just identifies patients who are more likely to die because of underlying morbidities, for example, cancer. And immediately think about the cancer trials of venous thrombosis prevention and treatment. Very effective to use anticoagulants to prevent venous thrombosis, but absolutely no mortality benefit. Or maybe anticoagulants, at least in primary prevention, prevent minor VTE, but not fatal events. Now, whether you consider VTE an unmet need in terms of less than expected effectiveness is up for debate, but we'll move on to the next area. Now, this is atrial fibrillation. And here we know that anticoagulants will reduce the risk of stroke or systemic embolism by about 80%. Again, remarkable. And it saves lives. Clearly, strokes in AF cause death that is preventable. So again, is there an unmet need? Well, think about the epidemiology of atrial fibrillation. It affects 1 to 2% of the population. The mean age of diagnosis is about 75 years. The life expectancy on average, now it definitely does not apply in every country, but in many established market economies, the life expectancy is in the low 80s, so that's 5 to 7 years of life expectancy. And despite anticoagulation, the annual risk of stroke is 1 to 2%, and the annual risk of major bleeding is 2%. So during an average lifespan for patient AF, the cumulative risk of stroke with effective anticoagulation is 5 to 10%, and major bleeding is 10 to 15%. What about mechanical valve thrombosis? And you all know that warfarin is, or at least vitamin K antagonists, are the only proven effective therapies to protect patients with a mechanical valve against thromboembolic complications. And we routinely speak to our patients facing valve replacement. And if they're young, we say, get a mechanical valve. It's going to last you for life. You need to take this drug, but it's very effective. And as long as it's well controlled, it's also safe. At least that's what I used to tell my patients. Is that true? Very provocative paper, European Heart Journal 2017. Meta-analysis of trials conducted in the past 2 decades obtained best estimates of treatment effect on thrombosis and bleeding in people with mechanical valves treated with anticoagulants. And here are the estimates obtained from this, they call it a microsimulation study. For a 45-year-old undergoing mechanical valve replacement treated with a vitamin K antagonist, life expectancy is about 19 years versus 34 in a general population. And the lifetime risk of thromboembolism, 18%, bleeding, 15%, and re-intervention that may not be thrombotic related, but 10%. So if you have a 45-year-old, and if you're like me and you say to them confidently, have a mechanical valve, it's good for you and it's going to last forever. Well, not forever. Remember that the lifetime risk of thrombosis, bleeding, or reintervention in a patient aged, in fact, I said here 25 to 50 at the time of the valve, is something like 30 to 50%. So unmet need, I think we can agree we want better therapies. And finally, atherothrombosis. I'm not going to talk about that in any detail. We showed recently in the COMPASS trial that adding low-dose rivaroxaban to aspirin further reduces the risk of thromboembolism. But if you look at the red line, these are the events that are not prevented. And just to remind us that 99% of all acute MIs, of all acute strokes, and maybe it's not 99, but let's say 98, and of all acute peripheral limb ischemic events are thrombotic. And whilst it's not realistic to expect that we're going to prevent them all with antithrombotic therapy, it certainly seems to me like an unmet need. Well, we've talked about the problems of existing anticoagulants related to contraindications. I've talked about limited effectiveness. Very briefly, the bleeding story. I don't have time to go into this in detail, but we've spent the last 15 years evaluating not only the incidence of bleeding, but the consequence of bleeding. And bleeding prognostically is as important on average as myocardial infarction and stroke. And that comes as a surprise to many. It's time we started considering bleeding an event in its own right. In the same way that we try to prevent MI and stroke, we've got to start thinking more consciously about preventing bleeding. But why do I mention this in terms of the anticoagulants? Well, just one slide, a striking example of how common bleeding is. With our latest and greatest direct oral anticoagulants, apixaban, edoxaban, dabigatran, and rivaroxaban, the annual rate of any bleeding, if you go to the trials, is somewhere between 15 and 18 or 14 and 18%. The annual risk of major bleeding is between 2.1 and 3.6%. On average, if you restrict it to people with the CHADS-2 score of above 3 or more, it's almost 5%. And bleeding is important, not only because the bleed is bad, it brings people to hospital, it needs treatments, etc. Not only because bleeding is prognostically important in terms of long-term outcomes and survival, but the third reason why bleeding is bad is even minor bleeds. Most of these are what you and I might consider negligible in terms of severity. They lead to discontinuation of effective antithrombotic therapy. Well, we've got unmet needs clearly in terms of contraindications, effectiveness, and safety. What would be the ideal new best ever oral anticoagulant? In order for such an agent to be viable in clinical practice, I'm going to suggest to you that such agents should retain the practical advantages of DOACs. In terms of pharmacology, they need to be non-renally cleared. And in terms of clinical efficacy and safety, we need safer drugs, first and foremost. If we get very safe drugs, we may be able to push up their intensity and thereby also improve efficacy. More on that in a moment. Well, how might we achieve such an ideal class of new oral anticoagulants? And I suggested at the outset that the most exciting area of research in this field, and this is moving very rapidly at the moment with multiple phase 2 trials in progress as we speak, and phase 3s to start soon, the most exciting area is targeting individual coagulation proteins in the contact pathway. Now here comes the dreaded coagulation cascade, and it ought not to be dreaded, but it is dreaded by many clinicians. Conceptually, coagulation is very simple. It's like an inverted Y. There's a tissue factor pathway, there's a contact pathway, and there's a common pathway. And really, that's all we need to remember when we think about the concepts of coagulation. Anticoagulants, up until today, the target has been to block thrombin. Whether you use warfarin, heparin, low molecular weight heparin, rivaroxaban, apixaban, edoxaban, dabigatran, you name it, and any anticoagulant, we want to block thrombin. But immediately you will see the problem with this approach, because thrombin is not specific to thrombosis. It also is essential for bleeding. All of our efforts till now and all of our use of anticoagulants tries to hit the sweet spot so that we can maximize efficacy and we can minimize the risk of bleeding. And it's all a sweet spot issue. Can we push it up? No, can't go any higher because we get too much bleeding, let's drop it. Imagine we could uncouple hemostasis and thrombosis. Now, if you follow the literature, you've heard this story before, and so far, it's not been possible. But there is emerging evidence that targeting the contact pathway, and in particular, targeting factor 11 or factor 11A, will uncouple thrombosis and bleeding. How is this possible? Well, let me try to explain. When we think about hemostasis, we're thinking about someone typically who has trauma, who is in a car accident or who has some local trauma, or a surgeon puts a knife into them, some disruption of tissue. When that tissue is disrupted and blood vessels are broken, a large amount of tissue factor is released, a huge amount. And this tissue factor activates the tissue factor pathway and generates an enormous thrombin burst. And this thrombin burst is enough to initiate and to begin to amplify and consolidate the clot. There is very little involvement of the contact pathway. How do we know that? Well, if we have someone with congenital factor 11 deficiency, hemophilia C, and their 11 level is 10 to 20%, they have close to normal hemostasis in most situations. There is not much of a need to amplify thrombin generation involving factor 11. Factor 9, yes, further downstream amplification takes place with thrombin, but not factor 11 or 12. Now let's go to a different situation. Here we have pathological thrombus formation. We're not rupturing a vessel with extensive tissue injury. We have inside a blood vessel a local area of inflammation which becomes atheroma, which becomes unstable, which then ruptures or fissures, and there is superimposed clot formation. In this case, the amount of tissue factor is very modest. And I'd suggest, although I can't prove that, but it's likely that in most cases, the thrombin burst is inconsequential and doesn't lead to thrombus formation. And there is a hint to support that, because when we look at people with vascular disease, we know that they have thrombus turnover, they're making D-dimer, they have elevated circulating levels of D-dimer, which can only form when you break down clot. But in this situation, if pathologic thrombus is to form, we need to amplify thrombus formation through factor 11. Now, what's the evidence for that? Again, if we look at the hemophilia C story, people with factor 11 levels of 10 to 20% not only have little bleeding, but they also have little thrombosis. So here is the concept that we're going to uncouple thrombosis and hemostasis. If you want to read a lovely article about this, this was published in the Journal of the American College of Cardiology recently. This is a schematic representation of processes required for hemostasis. Here we have hemostasis. There is tissue factor, which drives thrombin generation. There is also activation of factor 11 by tissue factor, and there is feedback on factor 9, but there is very little requirement for feedback on factor 11 to consolidate the plaque, the thrombus. When we look at pathological thrombus formation, so the first was hemostasis, here we have thrombus formation. And immediately you will see, at least conceptually represented here, factor 11 plays a much more important role in consolidating, in amplifying and consolidating this clot. Now, there is another plus by targeting the contact pathway. And this second plus is not only can we disconnect thrombosis and hemostasis, but we also specifically target the pathway that is activated when a foreign surface, such as a valve or a catheter or some other foreign body that we put into blood vessels, when that is exposed to the blood. So we could kill two birds with one stone. We could have uncoupling of thrombosis and hemostasis. We could have relatively preserved hemostasis with less thrombosis, and factor 11 inhibitor might also be perfect for people with mechanical valves. Here is a schematic which shows how the various anticoagulants work. So you see heparin knocks off or inhibits 10A and 2A. It affects the common pathway very strongly. It and almost entirely blocks the amplification required for hemostasis through factor 9, and you see a lot of bleeding. Warfarin is the same. DOACs, we've hit the sweetest spot, even though the targets are not that different to heparins. I think with the designer drug and the careful dose finding, we hit the sweet spot, so we get less bleeding. But here is the potential for a factor 11 inhibitor, very little bleeding, and effective thrombus prevention and treatment. What's happening in factor 11 or 11A inhibitor development? Here are the three classes of drugs in most advanced stages of development. There is the antisense oligonucleotide. This is an oligonucleotide sequence, which is complementary to the mRNA for factor 11. It can be given preoperatively. It lowers factor 11 levels down, and you can go to surgery with a factor 11 level of 15%, and you can have your orthopedic surgery without issues of bleeding, and you can prevent thrombosis. Some downsides here: it's got a very long half-life, but it does have no renal clearance and low drug-drug interactions. This is starting to look like one of those ideal agents that we talked about earlier on in the presentation. There are a series of monoclonal antibodies. I won't go through the trials. They're also attractive in terms of their pharmacology, but these are both parenteral agents with long half-lives. I personally believe that the most exciting are the two small molecule inhibitors, asundexian and milvexian. You'll start to see these in the literature. A trial with milvexian was just published in the New England Journal of Medicine. These are DOAC-like drugs. I'm inclined to call them second-generation DOACs. They selectively inhibit the active site factor 11A. They have a long half-life and are suitable for once-daily dosing, although whether we'll go with twice daily or once daily remains to be seen. They're very little renally cleared. So far, we don't know much about drug-drug interactions. And by targeting 11, they have the potential, which we're starting to see realized, that we can stop thrombosis without bleeding. What's the evidence for that? I'll show you that just in one slide in a moment, but these are the trials completed in phase 2. There are more emerging all the time. In total, knee replacement in end-stage kidney disease with the antisense oligonucleotide, in hemodialysis and knees with the antibodies, and milvexian, the axiomatic trial of 1,242 patients in total knee arthroplasty. One slide to show you efficacy. I'm sorry, but it's pasted directly from the New England, and it's small to see, but here we see efficacy increasing twice daily dose. We go from 21 to 11 to 9 to 8% event rate on venography. Once daily, the same dose response. And with the higher doses, we beat out enoxaparin, but there is no dose response for bleeding. So a flat line for clinically relevant bleeding and a not quite flat line, but a very stable line for any bleeding. So we're getting dose response for efficacy and not for bleeding. This is looking very promising. I'm conscious of the time. I will be very brief. I've been speaking now for about 35 minutes, so I'll be done within 5 minutes. Whilst targeting the contact pathway of coagulation is super exciting, and I think that's where the action is going to be. We have to keep our eyes on other approaches to prevent coagulation activation. And here I think about targeting upstream drivers of coagulation activation. We've spent almost all of our efforts targeting coagulation proteins, but clearly there's something that activates coagulation. And maybe we're better off in the long run by targeting those upstream drivers. And maybe it's less necessary to target the coagulation proteins themselves. Well, of course, we know about not targeting coagulation proteins with mechanical methods. We can reduce venous thrombosis by intermittent pneumatic compression devices on the legs. We can prevent stroke and AF by left atrial appendage occlusion devices. We can remove clots and we can use thrombolysis. So, of course, there is a certain element there, but most of our efforts to modulate coagulation have been with anticoagulants. But what if we could target, for example, inflammation? And this is a great story, the link between inflammation and coagulation activation. I'm not going to go into it in any detail, but we know that there is very close crosstalk between inflammation and thrombosis. If we look at what's been tried till now, there have been the sort of the blunderbuss approaches. Let's give people glucocorticoids, it's anti-inflammatory. Does it prevent thrombosis? No, it's useless. Let's give anti-inflammatory drugs, non-steroidals. Does it reduce thrombosis? No, it increases it. We know from glucocorticoid and non-steroidal trials that clearly these are off-target side effects that are causing harm. But we now have accruing evidence that targeting inflammation somewhat more selectively with drugs that are safer can prevent thromboembolic events. Statins are the first example. Here are 2 trials of statins in primary prevention. The HOPE-3 trial from McMaster, the Jupiter trial from Boston. In both trials, based on relatively small numbers, we're halving the risk of thrombosis. Why would statins prevent venous thrombosis? Well, we know that most venous thrombi arise in the pocket behind the valves, in the veins of the lower limbs. There is tissue, there is stasis of flow because the blood flow here is very slow. The endothelium depends on blood flow for its oxygenation because it doesn't get fed in any other way. When the blood slows, there is inflammation of the endothelium due to hypoxia. This inflammatory stimulus drives thrombus formation. Perhaps when you give a statin, you reduce the inflammatory effect of hypoxia here. I don't know, but it's kind of a plausible explanation. The bottom line is it works. Here is a systematic review we presented and published recently on colchicine to prevent thrombosis. Now, this is arterial thrombosis, not venous thrombosis. I'm not sure that we've shown that venous thrombosis can be prevented, but so far, no dedicated studies. So colchicine is a possibility, and of course, canakinumab. Last slide before I conclude. What else can we target in terms of inflammation, rather than those blunderbuss type approaches, or maybe the less blunderbuss, but still only semi-selective approaches to target inflammation? We now know that this crosstalk between inflammation and coagulation activation is intimate, and it is increasingly well characterized. For example, we know that when the lining of blood vessels is inflamed. We get neutrophil, we get monocyte, we get platelet activation, we get formation of neutrophil extracellular traps. Platelets release polyphosphates, and the polyphosphates drive contact-induced coagulation activation. Tissue factor released or exposed, and monocyte activates the tissue factor-induced coagulation activation. So very close link between inflammation and activation. And if we could selectively target, say, NETs, or we could selectively target polyphosphates, or we could selectively target monocytes, that's a little bit further away, then perhaps we could stop the drive of coagulation activation and thereby prevent thrombosis. There are some very exciting new molecules around. I don't have time to go in those. I'm going to conclude here. Professors Lowe and Jacobson, friends and colleagues, ladies and gentlemen. In 2022, in fact, it says 2021 when I prepared this, but it is now 2022. Clinicians have access to an unprecedented array of therapies to modulate coagulation and platelet activation, and thereby to prevent thrombosis. Despite these huge advances, important unmet needs remain, and concern about the risk of bleeding is an ever-present barrier to appropriate anticoagulant. I'd suggest the most promising new anticoagulant targets are those involve upstream coagulation proteins in the contact pathway, but there's a lot happening, so watch this space. And I thank you so much for your attention.
Well, thank you very, very much. Let me see. Thank you, John, for an absolutely outstanding talk. We're going to try and it's now open for questions, and let's see if we have any questions for. No one's put it on the chat yet, but I'd like to maybe, well, just a couple of points. Firstly, your very interesting talk about the lack of improvement in mortality. What do you think about the original work done by Vijay Kekar and the fact that nowadays we don't do post-mortem studies, and maybe what you're seeing is the fact that there are no post-mortem studies to do that? And I'm just concerned that I would hate our registrars to walk out thinking that anticoagulation is not necessary, because we have a lot of problems, especially with our orthopedic surgeons who are very reticent to give anticoagulation. So I think I'd just like to, maybe you could address that question.
Certainly, and it's a great question, and I'm deliberately being provocative, and
no, I understand that.
But I should clarify, we're in the middle at the moment of a trial, a 20,000 patient trial, comparing aspirin with anticoagulation in hip replacement. And this is being done out of the US. I'm on the steering committee, and I think we're going to show that aspirin is no less effective than anticoagulants to prevent mortality in patients at risk of venous thromboembolism. And I think the reason is that there are a number of relevant considerations. I'm aware of the Kekar study and earlier studies, but the Kekar study is probably the most impressive, showing the mortality reduction. That was done was it done in the 70s? I think it was published in 1976 or thereabouts, maybe a little later. I think a lot has changed since those days, and we are dealing with patients. We're rapidly mobilizing them. We're using regional anesthesia. We're using much better drugs. And I suspect that that's had a major impact. I think that some of the earlier studies on mortality have assumed that if you die and you have a post-mortem and there's clot in your pulmonary arteries, that the cause is a fatal pulmonary embolus, which I think is we now know that there's far more pulmonary embolism around than we ever could imagine because of the use of CT pulmonary angiograms. So perhaps there's a middle road, and I'm not saying to the registrars, don't go out there and use your hospital mandated protocols, because you need to be absolutely sure before you withdraw this therapy that's been in practice for 30 years. But the data are the data, and how else would we explain that we're not saving lives when we use uniform prophylaxis? I think that's the conundrum.
No, it's a very interesting conundrum, but having personal experience, I've done a lot of medical legals for a lot of orthopedic surgeons who don't give prophylaxis. And I've seen quite a few deaths in that group. And maybe they're not doing the same techniques that the North Americans are doing. The second question I wanted to bring up and just to discuss was the problem with HIV. So, and the use of antiretrovirals, anything to do with an ear or CYP inducers. And that has caused a major, we actually, when we did the Einstein study, I don't know if you know, I'm sure you know Ton Lensing.
Yes, yes.
So Ton and I did a sub-study within the Einstein study, and to my great embarrassment, we have never really published it. And one of my things to do, hopefully this year, is to get hold of Ton, and we need to publish that, because that was very impressive, because we adjusted the dose for patients on the Einstein DVT PE study who were taking antiretrovirals. I mean, that's the critical issue about the renal. So I do think that's a very important point, because we have an epidemic of thrombosis in South Africa due to HIV, and due to both treatment naive and treated patients. We have problems in pregnancy, and I don't know if Elise, I don't know if she's online, but she's doing a PhD, Prof. Elise Shapkat is doing a PhD specifically addressing this problem of thrombosis in pregnancy related to HIV, and it is an epidemic. I mean, you go to these meetings, and that's maybe the third thing was TTP. You know, you go to a meeting at the ISTH, and the ex-world expert stands up and speaks, and he's seen 10 cases in his life, and you know, we're seeing 2 to 3 cases a month, and so we have. It always fascinates me. And we have Susan Lowe, she's on board. Maybe she'd like to say a few words about her PhD, which is actually on. Susan, do you want to actually unmute yourself, or can you unmute yourself? Estelle, can anyone unmute themselves?
Yes, Mr. Jacobson.
Oh, there you are, Susan. Right.
I'm here.
All right. So do you want to maybe share with us what you're busy doing? And it's very exciting work, and we hope to finish your doctorate now soon.
Good afternoon, everybody. Thank you, Professor Jacobson, for this opportunity to speak. Yes, as you've alluded to, that we are encountering a condition that we have been calling HIV-associated TTP. And the hypothesis at the moment in the unit is that we are possibly dealing with an TTP-like syndrome in patients that are infected with HIV, in that the pathogenesis probably revolves around endothelial activation and endothelial dysfunction with excessive release of von Willebrand's factor, which overwhelms the ADAMTS 13 proteolytic capacity. And we're busy just assaying and looking at complement activation in these patients, and also endothelial dysfunction. So yeah, that's what we are in the process of doing. Thank you very much.
Thanks, Susan. But maybe to go back to some more questions for you, seeing that everyone's very shy of you, John. They're too scared.
Harry, maybe I can drop in a question.
Oh, brilliant. Thanks, Vernon.
John, thank you for a fantastic presentation and presented fantastically. I really enjoyed the way in which you made things that I often find difficult so much simpler. I want to ask you about this factor 11 inhibition. There's such a close relationship between the hemostatic system and the immune system. And my question is, what are the off-target effects of blocking factor 11? Is that also in some way connected to the immune system? Should we worry about that if long-term use would be part of our paradigm? Or is it a very narrow, limited role that it plays in the hemostatic system?
Thanks very much, Vernon. And I have to confess that this is not something I know much about. My impression has been that it plays a rather a minor role. But your question is excellent. But that's also obviously why we do the trials, that we need to look at this. We will have to await the results of randomized trials. As you know, the duration of follow-up is probably not going to be more than 2 or 3 years in most of those trials. From my understanding of the biology, I think it plays a very low role, very small role, but we will have to wait and see. Can I chip in with one other comment about HIV? Because Barry, you said this beautifully. You see the world experts stand up and talk about 10 cases. I came to UCT here, which you know how spectacularly successful they are with their trials, which are absolutely mind-blowing. I went to a hospital and I saw a patient with TB in their blood. And I said, look, I've been in medicine for 30 years. I've never seen that. Like the stuff you see here, that's why others can't tell you what to do. You have all the experience here with these diseases. So it's very humbling, but also very educational to see it.
So that's why you chose Cape Town, not for the view.
Well, a bit of both.
Well, just to go back to the immune system for Vernon, I mean, we've never really seen patients with factor 11 deficiencies have immune problems. So it's unlikely that I think that they would have immune problems. I think it's unlikely.
But I think the question is, how often do we see factor 11 deficiencies, and have we looked?
That's a good point, but they live to be, because it's the commonest cause of hemophilia in Israel, so-called Rosenthal syndrome. And it's been well described there, and they don't seem to have immune problems. I've had one patient, actually, a doctor's mother, actually pass away, and that's because she had inhibitors, because she'd got blood, and we plasmapheresed her, and then she got a pneumococcus meningitis and died. But generally, it's not a major point.
No, looks very promising, I must say. I must admit.
It looks too good to be true. But I'd just go back to the warfarin issue. So we stuck with warfarin here, John, and because of the costs. I think that the other point is that these medicines are all great, but with a rand-dollar exchange, they're never going to be really realistic in the South African context because of the costs. And we really are stuck here with warfarin for a long time to come. The point is made that we have got now that rivaroxaban is off, their patent has run out. We've had a whole lot of generics come onto the market. And then what we have found with, like with enoxaparin, that a lot of these generics don't work because they're supposed to be not generics, they're supposed to be biosimilars for the low-molecular weight heparins. And I've got quite a lot of experience using them in the patients now with COVID in the ICU and measuring their 10A levels and finding that some of these generics are not really working, or the biosimilars, both with the biosimilar for enoxaparin and the generic for rivaroxaban that I have been using. And it's a critical issue for us, especially for rivaroxaban, because with our so-called anticoagulation INR clinics, in the presence of COVID, we've had to modify in fact, I've got one person doing his master's on it, because we managed to get the government to pay for rivaroxaban during the COVID first epidemic, the first wave, so that we could allow these patients not to have to come into the hospital, because that's a critical issue that we're worried about them getting sick. So warfarin remains the backbone for us for patients with heart valves. I'm curious that you said that you thought it might work for valves. I'd be a little bit hesitant until I had really good animal model to do that. And we don't use the rivaroxaban for patients in renal failure currently. We're using warfarin. I take your very valid point that I teach all our registrars about the cumulative problem of bleeding of 1% per annum, and that's cumulative. And I think that's a very valid point that we need to make. that warfarin is given. You know, when people give insulin, they're very worried about killing the patient, and the doctor takes a lot of time and trouble prescribing the insulin and explaining to the patient exactly, you know, the dangers of hypoglycemia and hyperglycemia. But they quite glibly write out warfarin and say, take one tablet a day and good luck to you, and off you go to the PI clinic, and they don't really understand the implications of putting someone onto warfarin. And I think that's a very important point, that and the costs associated with it, that we need to be very aware of how we prescribe it and the risks, and that it should be done. And we know that nurses often do better than doctors in managing the anticoagulation. And I think that's a very valid point that we need to be able to do. I see that
there's a question from Johnny.
Yeah.
Sorry, John, go ahead.
Actually, the question would be better than what I was about to say, but I'm actually intrigued by, you've got 3 wonderful little projects, or big projects there. I mean, your TTP HIV is beautiful. You've got this bioequivalence. We're doing a bioequivalence study at the moment with the Digatran. I think that's incredibly important. And then, of course, you've got your Einstein study. That's another spectacular set of science that I'd love to see in print sometime. So if you ever want help in any of those, I'd love to help you. It's really exciting. But Johnny wants to, Johnny Malangu.
John.
Thank you. Good afternoon, colleagues, and thanks, John, for that very, very insightful presentation. I mean, this is quite enjoyable. My question is actually threefold. The one component is your comment around excluding patients with chronic kidney failure from clinical studies. And I just want to know your take on that practice, given the very large number of patients around the world with chronic kidney failure. Sometimes we do wonder what is actually the rationale of excluding such patients. And it's not just obviously in the studies that you described, it's in many other studies. The second question relates to using rebalancing agents to try, obviously, and get the hemostasis back to balance, whether you are on the one extreme of either bleeding or thrombosis. And what I want to know is, what are your takes on the unintended consequences that may well arise? For example, we do know that some of these molecules are critically important in preventing cancer, for example. What should we be interpreting the good results of these studies versus the unintended consequences? And the last question relates to all of these molecules, whether you're using them in the context of anticoagulation or preventing bleeding. Unfortunately, they are foreign enough to cause immunogenicity. And I just wanted your comment on the extent of us being worried about immunogenicity of these molecules.
Thanks very much. Appreciate the questions, and I wrote them down as you spoke, so I'll remember them all. So CKD, I think it's a complex issue, but when new drugs are developed, inevitably, so let me start at the beginning. I think we've decided as a community, as a society, that we won't develop drugs. We're going to leave that to private industry. And private industry needs shareholders. Otherwise, they're not going to earn money, and they want them to invest. So private industry says, I need to make the most money I can. So when they go and develop a drug, they say, I'm not going to use a high-risk situation. Anybody at risk of intracranial bleeding, anybody with CKD, anybody with liver disease, we're just not studying them, because if we don't get our 15%, whatever it is you need to make your company viable, our shareholders will leave us. So until we as a scientific community, or perhaps as a society, say, we're not doing this, this problem is going to perpetuate. Now, there is a little bit of light at the end of the tunnel, so to speak, because I think some of the pragmatic trials now, we're doing one in collaboration with folks at this George Institute in Sydney, looking at low-dose rivaroxaban in end-stage kidney disease, looking at a DOAC in atrial fibrillation with end-stage kidney disease. So it is going to happen, but that's the quick take on exclusion. 2 and 3, you know, it's tough. We say, is there a negative consequence of giving either an anticoagulant or a procoagulant or whatever? If we modulate the coagulation system, what are the unintended consequences? Well, to state the obvious, they're unintended, they're unknown, so we don't know. All we can really do is point at, say, something like warfarin, which is used 20, 30, 40, 50 years. We're starting to see, for example, calcification. How real is it? How important is it? We're starting to see deterioration in renal function compared with a DOAC. How real is it? How important is it? It is probably real. It is probably important. But that's the sort of follow-up I think we'll need to ever detect these signals. And immunogenicity, in the early studies, of course, there's a lot of careful study of potential activation of the immune system or antibody formation. That's the best we'll have. I suspect that the problems are much less than what might be feared. But until it happens, we won't know. I suspect, though, that the benefits clearly outweigh the risks in most cases, and that's why we go on. I see the question about TTR and in the chat, and the time and therapeutic range. I mean, it seems such a fundamental concept. It's actually quite tough for the busy jobbing clinician to get their heads around, but just so critically important. In some of our trials, what we've done is we've provided centers with an algorithm, just on paper. If your ionized X gives so much, if it's Y gives so much. And we don't calculate the TTR by the Rosendahl method, but we just count how many INRs are in the range. I mean, it's rough enough, it's good enough if you can't do better. But even with these two simple approaches, you can improve a TTR from 30% to 50% overnight. And so I think there is a lot of potential, and your society has a wonderful opportunity, and dare I say, perhaps a responsibility. I'm just being provocative, but maybe it's an opportunity to try to disseminate information, because I do think, as you say, warfarin's not going to go away forever.
No,
for a long time yet.
We actually do that. So we offer a training course through the SS, through, and actually we have to the laboratories, to the PR clinics. So we try and train up people throughout the country to try and ensure the TTRs, because we have our TTRs are not that great, to be quite honest. In two of the studies that we did, they weren't great. So we have gone a long way to try and making sure that we can improve the TTRs. And we also have a lot of heart valve patients here because of we have the largest number of pregnant patients with heart valves in the world, because we have the mix of first world and third world. We have third world where patients are still getting rheumatic heart disease, and first world where we have the ability to replace their valves. So because most of the valve replacements done in the first world are done on the elderly patients who are no longer reproductive. So we still have a lot of patients. We've published, I mean, the largest studies have been done on managing pregnancy patients with heart valves. We have ongoing research projects on that with Arun Remtula, so running those clinics. So we have very active clinics doing that. But South Africa is a unique country because of the mixture between first and third worlds, as you've no doubt noticed.
I see there are two questions in the chat box. One from Dr. Clint. Well, actually, Clint has got his hand up and something in the chat box. So I'm going to give him a chance first, because I guess his question might relate to his chat from earlier, which we just spoke about. So Clint, you go ahead, and then we'll talk about the cannabis.
Afternoon, everyone, and thanks for an amazing meeting so far. I just saw the link earlier on at about 10 to 4, and glad I joined. Yes, so clearly Prof. Jacobson has said that South Africa is not moving away from warfarin anytime soon. And we have a major problem with our PI clinics because we aren't measuring time in the therapeutic range. And we actually are not training anyone at a university level. And being at a small hospital, I have interns from all over the country, and there is no known university that I'm aware of that actually has a lecture on managing warfarin after you have made the diagnosis for the indication of warfarin. So many of the INR or PI clinics around the country are often run by community service doctors that are rotating through there, and in fact, often by interns who have never had any training in this area. And I really think that we need to, I'd love if we could move to the newer agents, but we have to deal with the reality. And so we're still doing a lot of research at the moment with regards to warfarin usage. But, in the chat box, I see that the Free State has been able to get rivaroxaban onto the code list. So I'm amazed at how we're living in a country that also seems to have very different provincial guidelines, and that we aren't able to, as a hematology fraternity, to be able to actually move country into the first world, but also the difficulty of dealing with INR clinics and the mere fact that we see more warfarin toxicity than I believe we are getting benefits from warfarin, because we're not doing the job properly. Thank you.
Thanks, Clint. I mean, I don't know. I give talks to the finalists. Maybe they don't come to those talks because they're too bored, but I give talks to the finalists and to the dentists on warfarin and how to manage it. So I think that if they didn't come to the talks, I can't explain that, but they do get lectures at WITS on managing of warfarin in final year. I talked to the final year surgeons, because students actually, because of the going to discuss bleeding and how to manage bleeding. And we do give those talks, but your point is taken that we need to be maybe more proactive in making sure that people are aware of warfarin and their complications. And we have offered advice to the formulary and have been applying for 2 years now to try and get it onto the formulary. So that is that is being done.
Maybe
for the national formulary. So we've applied under the national formulary to have rivaroxaban available under the national formulary.
Maybe a quick comment about warfarin, because it's not unique to South Africa that there are areas where it's very poorly managed, and I mean every country is afflicted by it, at least in certain regions. I think the key is the day-to-day experience. Nothing compensates. We can have lectures, and that's important. But unless you're dealing with the cut and thrust of the simple warfarin dosing, it's very hard to pick up the skill. And I wonder about, we now run a clinic that remotely manages warfarin, where the INRs are done around the place, even 100 miles away. But they just, the lab just puts it online, and the central place gets the INR. And now I'm sure that's not as simple to do in South Africa, but centralizing the services as much as possible may be an option.
Yeah, we've had many challenges because our hospital burnt and we couldn't have any access to our patients. I don't know if you're aware, we had a major fire at our hospital.
Yes.
And we've had been a real problem. I went to national TV telling people were dying because we didn't know where they were going. And I think people don't really appreciate the dangers of warfarin therapy. So we have made a major attempt to try and get rivaroxaban, being onto the national formulary, but it's not easy, and we're a country with very limited resources, and that's the problem. Anti-11A inhibitors are going to be way out of the range of the average South African, to be quite honest.
I think we'll have to. Sorry, John.
No, please. I was hoping that it'd become much cheaper the generics, and that they'd be affordable. But as you say, if they're not good quality, that's a key area for exploration.
I think the problem is that all the drug development is done in, and the target market is North America, and they target it in dollars. And with the rand being 15.5 to the dollar, there's no ways we can ever afford anything, to be quite honest, from any of the newer medications, which is very disheartening from an academic point of view, trying to teach people what therapies are available and actually having none of them, financially viable, even in the private sector. It's not really viable.
We quickly moving towards the end of the meeting. I would like to, just before Barry, while you get your slides ready, I'm going to ask John if he wants to comment, or maybe somebody else in the room, on the drug-drug interactions between synthetic cannabis or cannabis-like products or cannabis extracts, and whether you've got any thoughts on that. And then Barry will just do a 5-minute introduction to the South African Society for Thrombosis and Hemostasis. And this is also something we aim to do in this year, is to introduce all the different societies and groups to the larger team, so that the trainees and maybe others can come to know what is happening in hematology. And you'll be surprised at how much is actually happening, and some really great things. So Barry, I'm not sure if you've got slides, or you're just going to speak, but nevertheless, maybe John, you can just comment if you would like to.
I'll be very fast. Cannabis, it interferes with warfarin. I don't know that it interferes with rivaroxaban, but I could be wrong. So I'll have to plead that. What is it? Which amendment for that? I don't know.
Right, thank you. And then I just want to mention the link for CPD is now in the chat box. It has been there for a while. Just scroll up and click, and you can do the rest. So Barry, would you like to just share with us briefly about the SASTH, please?
Thanks, Vernon. I don't have any slides, so I've just been too busy today. But the SASTH Society, it's actually the Southern African Society of Thrombosis and Hemostasis, was founded by myself, and I see Pete Wessels on the line here, and I'm sure John will know. It was also Sylvia Haas was integral in starting it, and the other key members in our society have been Lord, and I see just been made knighted now as Lord Sir A.J. Kekar. So we have some very prestigious overseas people, and Harry Bueller have been instrumental in getting our society up and running. And we have an annual meeting, and we have a non-profit organization, and we've taken on the management of Gaucher's, because it was an orphan medication. So we actually run and fund the Gaucher's clinic in Johannesburg, the Rare Disease, under the Rare Disease Society. But our major thrust has been education, in terms of educating people on anticoagulation and setting up and trying to train nursing sisters throughout the country with on managing INRs. We also have our latest major strategy is in COVID, in where we've been instrumental in writing guidelines to try and manage TTS, and we are now embarking on a large. We're now embarking on a large study to look at thrombosis related to patients who've had vaccines, both in the Sisonke and the Sisonke boost. And we are trying to get up and running, very similar to what the Garfield study did, was to have a registry base throughout Africa, because what has become painfully obvious to us is the lack of data that is out there on the background rate of thrombosis in Africa. So when one looks at thrombosis, one has to always look at, especially when we're vaccinating millions of people, what is the background thrombotic risk? And we know the background thrombotic risk in Black patients in Africa, in America, is higher than in white patients. That's a well-known fact. We have no real good data, or very, very limited data, of what is happening in the rest of Africa. We have some data from South Africa, but not in the rest of Africa. So the thrust of the society is actually going to be looking at, firstly, within the southern areas, so looking at Namibia, Zimbabwe, and then moving northwards to both Kenya, ultimately Egypt, as well as Nigeria. And that's what we are trying to do. I will send out to all the people our prospectus of our society, of what we're doing, and to encourage people to become members. There's no real benefit for being a member other than the fact that you get to do research with us, and that you get a slight reduction in your fees at our Congress. But in the last 2 years, it's been virtual online, so there's been no fees. But that's basically what our society is trying to accomplish. Thank you for that time, Vernon.
Barry, that's fantastic. Thank you. And congratulations also on the good work done in the past. And we look forward to see what's happened. Don't forget about Botswana. I see Elizabeth Botsile is in the room, and she recently qualified as a clinical hematologist. So there is now a clinical hematologist there as well.
Oh, fantastic. Now we are going to be looking at Botswana as well. So we're going to look at Zimbabwe, Botswana, Namibia is our immediate, I forgot to mention.
Dr. Simba Kudakwashe, who's just completing his training with us, will be in Namibia in the next 3 or 4 months on a full-time basis. On that, or with that, I would just like to say, what a first meeting. This was really, really amazing. I think this was a fantastic start to the year. I want to just say special thanks to Prof. Stelverberg and her team that's been organizing these meetings, Gerdien Kritzinger, Dr. Gerdien Kritzinger and Melanie Davids, our secretary. They do a lot of work behind the screens to get every session organized, and one would be surprised what it takes to make sure that there's a topic and speakers and bios and CPD and videos uploaded and for every session. So thank you to all of them. We look forward to next week's talk, which will be closely related, although with a twist. The Free State, the University of the Free State team will speak on bleeding in plasma cell dyscrasias. So Jacques Malherbe and his team, we look forward to listening to that. I think that's also a very interesting niche topic, but that's very relevant to our work as hematologists. And I just by sort of glancing through the chat box, John, I can see so many comments on positive feedback with regard to your talk. Thank you very much. It's been a real privilege that you could come to University of Cape Town as a visiting professor. And thank you also for being willing to come to this meeting today. This is really, really very good. And I'm sure many people are going to access or hear about the session and want to listen to the video afterwards, or the talk afterwards. So with that, I wish you all a wonderful afternoon. We are well in time. There's 5 minutes left. I'm going to leave the session open for a few minutes so that those who haven't clicked on the link can do so. And then we'll see each other same time, same place next week, Monday. Thanks, everyone. And thanks, Barry, for being a fantastic co-chair. Much appreciated. Bye-bye.